Assalamu alaikum wa rahmatullahi wa barakatuhu. Welcome to the channel of Stand Medical Notes. So we are on the way of the cardinal manifestations of cardiovascular diseases, and we have discussed many of cardinal manifestations from this topic. So today onwards, we will have some videos on a very basic investigation which is inevitable nowadays, that is electrocardiography. So there will be some videos on this, and this is very much important. I thought that without this the chapter of this cardiovascular disease is incomplete, so we'll discuss this from basics to advanced. Okay, not only theory, but we'll have many strips of ECGs, many images of ECGs and all. So we'll decode that ECGs, hypertrophies, accessory pathways, except to arrhythmias which were discussed in the previous videos. We'll discuss everything here. Okay, so let's begin here with the name of the Almighty. So foundational, we should know the first foundation of the ECG, foundational principles of ECG. Okay, and what is the electrophysiological basis of the ECG waves? So what is basic ECG? Basically, it is a graphical representation of the Hertz electrical activity, depolarization potentials from the working atrial and ventricular myocardium. Okay, that means the electrical activity of the heart which is going on there is recorded in a graphical form by some instrument, that is nothing but electrocardiography. Okay, from that we will have information about the chambers of the heart, the electrical activity of the heart, many information. Okay, not all, but much information, important information like infarctions and all. So first of all, we will know the the electrical system of the heart. So what is depolarization? So remember, normally a cell is like this. The basement membrane potential of the cell is like this. So this is basement potential. So if some impulse, if you touch this, so this will become like this. Outside will become negative and inside will become positive. So this generates a current. Okay, this generates a current, and this is known as depolarization. This is known as depolarization. After some time, it will move on back to the its basement potential. So that is known as repolarization. Repolarization. Okay. So when this current is generated, there will be something called as electric electrical contraction coupling, which we have learned in what do you call physiology. EC coupling. Because of this EC coupling, there will be contraction of the muscles. The current is converted into muscular energy. Okay, so this EC coupling is responsible for the contraction of either skeletal muscle also, and same is the case for cardiac muscles also. So just see the wiring of the heart. See the wiring of the heart. So there is a pacemaker known as SA node, this one, and which acts as a boss of generation of impulse. Pacemaker, that is known as the pacemaker of the heart, because it will supply the current to the whole of the heart. And there is something is called as AV node, and this is known as the bundle of his. Then that divides into right bundle branch and left bundle branch. Left bundle branch further has left anterior branch and left posterior branch. Okay, and this will go to the left ventricle, this will go to the right ventricle, and from there there will be something called as like this fibers from these wires, which will penetrate in the uh, muzzle of the heart. So these fibers are known as Purkinje fibers, minute wirings, Purkinje fibers. So that's how the electrical conduction system of the heart is there. One more thing is, so this is SA node. So this is SA node. From the SA node, the current travels to the left atrium by this Bachmann's bundle, and to the AV node by this anterior internodal tract and middle internodal tract and posterior internodal tract. from here to bundle of his, then to right bundle, left anterior and posterior bundle, then Purkinje fiber, then contraction. That's about the electrical activity of the heart. Moving forwards, so because of that electrical activity and electrical activity, we will have this kind of ECG recording. Okay, uh, typical ECG recording on the heart. So remember, in this ECG recording, there will be three types of things. Number one is waves. Number two, intervals. Okay. Number three are segments. Okay. So the difference between the interval and segments is interval constitute a wave, but segment don't have any wave. Don't constitute a wave. So they are just a line. They are line without wave. So line without wave is segment. Line with wave is interval. And waves are waves. So there are three types of things which are graphically recorded on ECG. So let us see what are the important waves we see. So we'll have a P wave. Okay, we will have a P wave, and then we will have a Q wave, R wave, and S wave. Together, all of these waves constitute the QRS complex. Okay, the P wave, QRS complex, then T wave, and sometimes U wave. So these are the four, actually six important waves, but these three constitute one thing. So four important things, waves. Okay, next important things are intervals. So what are the intervals? So one is PR interval. So we starts from the starting of the P wave and to the starting of the Q wave. Then QT interval, important. So it starts from the starting of the Q wave to the end of the T wave. Then ST interval also you can take, but this is not much important. ST interval starts at the J point. This is known as J point. Remember, this is the J point. What is J point? The joining point of S wave with ST segment. The joining point of S wave with ST segment is known as J point. So starting from the J point to the ending of T wave is the ST interval. But the important, okay, this is ST interval. Then fourth one is RR interval. RR interval. So between two different QRS complex, the distance between the two QRS complex is known as the RR interval. So among these, the PR interval, QT interval, and RR interval are the most important intervals. So what are the segments? The segments are the PR segment and ST segment. Among these, the ST segment is the most important one. Where ischemia, we know from this the ischemia or MI, no. So this is the most. That's about all the things which we record on ECG. Okay. So this is a sum box which we have, which we should see. Okay. So P wave is nothing but represents atrial depolarization. P wave represents atrial depolarization. Remember this thing. PR interval represents the time gap between the atrial depolarization and ventricular depolarization. The time gap between the atrial depolarization and ventricular depolarization is the PR interval. What is that? The impulse slows through the AV node, his bundle, and Purkinje fibers. So this slowing is important for coordinated contraction of atria and ventricles. That gives, as it is shown here, it gives time for the ventricular filling. So if the ventricles are filling properly, so we will have a proper cardiac output. Okay. So PR interval. Okay. Then there will be a TA wave, something called as TA wave. That is nothing but atrial repolarization. But this is concealed actually. It is not visible due to overlap with other signals. So TA wave is atrial repolarization. So atrial depolarization, then there will be a gap, then atrial repolarization. Then this QRS complex represents ventricular depolarization. Ventricular depolarization. And T wave represents ventricular repolarization. And one point to remember here is the repolarization in the ventricle uh, uh, goes from the epicardium to the endocardium. Remember this point. Meaning, if this is the heart muscle, it is like this, and this is the cavity of the heart. So the repolarization is from the epicardium to the endocardium. It is not like this, endocardium to the epicardium. Okay. Then next, one more thing is U wave. So it is not saying, it is a sign of late repolarization. sometimes includes U wave after a T wave. It may reflect repolarization of the Purkinje fibers and the papillary muscle. So repolarization of Purkinje fiber and the papillary muscle. And one thing to remember here is, just remember, this part of ECG is atrial activity, and this part of ECG is this part total. This is ventricular activity. Okay, this is, one more time, this is atrial activity, and this one from here to here, this is ventricular activity. Okay. Okay, so we'll move forwards now. So coming to the, so standard recording conventions and grid metrics in ECG, this is important for the interpretation of an ECG. Okay, ECG ECG interpretation requires checking technical specifications on the millimeter grid. Remember, in ECG you will have, this is the large box. Okay, this is the large box, and this is in the large box small box. So we'll have this type of large, and under the large boxes you will have small boxes. Okay, this is important. And remember, one large box, and remember this point, grid orientation, time is in the horizontal axis and voltage is in the vertical axis. Okay, so that's why the large box, one large box is equal to 0.2 seconds, and one small box, width of one small box is equal to 0.04 second, as shown here. And also we will have here the height. No, height is represented by the voltage on the y axis. So one large box height is 0.5 millivolt, that is nothing but 5 mm. Remember, 5 mm. And height of one small box is 0.1 mm, that is nothing but 1 mm. So this, knowing this is very very important. Okay, very very important, we should know this. Okay, small box and large box and their metrics. And remember, the machine speed should be 25 millimeter per second. Okay, before recording ECG we should see whether the ECG is standardized to these values or not. If it is not standardized, we will have what do you call, defective interpretation of the ECG. Time metrics, one small square is equal to 0.04 second and large square is equal to 0.2 seconds. Calibration or sensitivity should be set to 10 mm. 10 mm is equal to 1 millivolt. Remember this one, 10 mm is equal to 1 millivolt, but 1 millivolt is equal to the height of two large boxes. Height of two large boxes. But the sensitivity should be set to this, 10 mm should be equal to 1 millivolt. This should be the sensitivity which should be set, or you can say 5 mm is equal to 0.5 millivolt. So this should be set in the machine. Okay, amplitude correction is required. See, same thing, here it is given, is required if standardization is mark is not equal to 10 mm. Deflection polarity, remember, whenever the current flows towards a lead, so it will have a positive deflection, and when it flows away from the lead will have a negative deflection. And when the lead is perpendicular, to the current, perpendicular, then it will have a biphasic wave in the lead. Remember this basic things. Okay, now moving forward, the dual lead ECG system which we use daily. Okay, anatomy and viewpoints. The dual lead ECG uses 10 electrodes and the Wilson central terminal to provide a 3D view of cardiac electrical activity. Basically, what is there? We will have six. So this, if this is the frontal plane. So we'll have six leads. Like here, there'll be AVR, AVL, AVF, and this is AVF. Here lead 1. Okay, and here will be the lead 3, and here will be the lead 2. Okay, so these 6 leads see the heart in frontal plane. This is frontal plane. So remember this as, these leads act as cameras which are looking the heart from different directions in the frontal plane. These 6 leads. So 1, 2, and 3 are the bipolar leads, and AVR, AVL, and AVF are the unipolar leads. Think this as cameras which is seeing the heart. If you draw a heart here like this, so see, The lead AVL is seeing from here, AVR is seeing from here, and lead 2 is seeing the heart from here, lead 3 is seeing the heart from here, AVF is seeing from here, and lead 3 is seeing from here. So these are the cameras. You can remember this as these are cameras which are looking at the heart in the frontal frame from different directions. So they will gather some important information from this. So this is the frontal plane. The next is horizontal plane. Horizontal plane means like this. Okay, and this is the frontal plane, isn't it? Okay, in horizontal plane we will have 6 leads, unipolar leads. That will be V1, V2, V3, V4, V5, and V6. So if this is the heart, so these leads are seeing the heart in the horizontal plane. Okay, these leads are seeing the heart in the horizontal plane. So these cameras, V1 camera, V2 camera, V3 to V6 cameras are seeing the heart in the horizontal plane in different directions, and we will gather information from that. And in sometimes in some you one some doctor can take V3R and V4R leads and V7, V8, V9 leads also. Will discuss about that. So limb leads. So there'll be limb leads, that is nothing but in the frontal plane, and there'll be chest leads in the horizontal plane. So bipolar leads are 1, 2, 3. Unipolar augmented leads are AVR, AVL. Bipolar leads between two electrodes, augmented unipolar. This one. And V1 to V6 are unipolar leads, precordial placement. V3R, V4R act as right-sided chest leads. These are used to exclude right ventricular infarction, especially with inferior MI. Remember one important point here: inferior MI, posterior MI, and right ventricular MI. Whenever they come in combo. Combo, I mean, this is not a rule, but if there is inferior MI, they can be associated posterior or right ventricular MI. If there is right ventricular MI, there can be associated inferior or posterior MI. If there is posterior MI, there can be associated inferior and right ventricular MI. That's why if any one of these three is there, then we should check other two also whether they are there. And remember all this, that is inferior infarction, right ventricular infarction, and posterior infarction present as hypotension. Present as hypotension. MI with hypotension. Okay, present as hypotension. And in some cases we will record V7, V8, V9 in case of these are known as posterior thoracic leads to assess posterior wall ischemia. Okay, now remember this one: 2, 3 AVF acts as inferior leads, 1 AVL acts as anterolateral leads. Actually lateral leads you can say, because they are present. One is here and AVL is here. Okay, so actually it is lateral lead. AVR sees the right atrium and to the cardiac activity. Activity and right atrium. V1, V2 sees the right ventricle, V3, V4 septal, and V5, V6 left ventricle or lateral leads. Okay, so remember these things, very important. So these are the cameras, and the part which the cameras are seeing are these things. So these cameras see this part, and these cameras see this part. These cameras see this part. These cameras see this part. This camera see this part. This camera see this part. These cameras see this part. These cameras see this part. Remember like that. Now, see. In the frontal plane, the unipolar and bipolar leads. So the mean vector, electrical vector of the heart is directed towards the second lead. Okay, remember, normally it is towards the second lead. So that will have like this type of ECG. Second lead will have this type of ECG. Now see, this AVL is perpendicular to this mean vector. That's why it is biphasic. Okay, and it is at minus 30 degree. Sorry, minus 30 degree. And AVR will always be negative. Remember this point: when if AVR is positive, no, so either the limb leads are placed incorrectly, or there is left main coronary MI. Okay, either of these two will be there. So if this is positive, the most common possibility is the limb leads are placed not correctly, and if they are placed correctly, then positive means left main coronary trunk in blockage and major MI is there. 3 at 120 degree. Also remember this, these things at 120 degree, AVF at 90 degree. Okay, now one thing, if you draw a line here like this straight, this will become minus AVF and minus 90 degree. Okay, and if you draw a line just opposite to this second lead, okay, this will become minus 2 and minus 120 degree. Okay, if you draw a line like this will become minus 1 and this is 180 degree. You draw a line with 2 3. Okay, so this will become minus 3 and minus 60 degree. So by this you will get this type of hexaxial diagram. This is helpful to know the axis of the cardiac electrical axis, because cardiac electrical axis changes in some conditions like left bundle branch block, right bundle branch block, or hypertrophy, or in some infarction. So that's why axis deviation is an important thing. Okay, so by remembering this chart also we can derive the axis, and we have other common methods by that also we can derive the axis. So the normal axis is here, from where to where. The normal axis is from 90 degree, or some books say 100 degree. This is 100. Okay, from 90 degree to minus 30 degree. Now if 3 is negative, okay, then it is minus, it is left axis deviation. Okay, and 1 is negative, then it is extreme left axis deviation, you can say. This from this to this is extreme axis deviation. So minus 120, minus 150, minus 180 are considered as extreme axis deviation, and plus 120 and plus 150 are considered as just what you do, you subtract here 30, 30, 30, 30. Okay, like that. So this is left axis deviation. So one more time, from minus 30 to minus 90 degree is considered as left axis deviation, and from minus 90 to minus 180 is considered as extreme axis deviation, and from 100 degree to minus 180 degree is considered as right axis deviation. Remember this, and this is normal axis. Just remember these things. Okay, if one pastes this diagram in his mind, so this is helpful in knowing whether it is right axis, left axis, or extreme axis. Okay, so how do you place the leads? So remember, lead 1, lead 2, lead 3, you know all. So you will have some neutral lead on the, here you will have the neutral lead, and here you will have the foot lead. Okay, and here you will have the left lead, and here you will have the right lead. This will be marked in the ECG machine actually, R, and there will be, this will be I think yellow, and this will be red, and this will be green, and this will be black. This will be the codings which will be given in the ECG machine. So these are the unipolar and bipolar leads. Now coming to the precordial leads, so where they are placed, we'll see this, just this diagram. See here, V1 is placed at right sternal margin in the fourth intercostal space. How do you know this fourth intercostal space? As you have learned in the anatomy, this is the, from this you calculate, this is the second rib, and this is the second intercostal space. Third rib, then the what do you call this, is angle of Lewis, no, angle of Lewis, from the angle of Lewis, this is second rib is attached. Below that will be the second intercostal space, then third rib, below that will be the third intercostal space, then fourth rib, then fourth intercostal space. So fourth intercostal space here will be the V1, then V2, left sternal margin, fourth intercostal space. So this will be the V2. Okay, left sternal margin, fourth intercostal space, left sternal margin, fourth intercostal space, and then don't go to V3, you just come to V4. Left mid clavicular line, I'll just remove this. So this is V1, this is V2. Okay, and this is V3. This is in the, if you draw a line like this from here, so this is in the mid clavicular line. Okay, but this is in the fifth intercostal space, and V3, now V3 will be in midway between V2 and V4. V2 and V4. So this is V1, this is V2, and this is V3. Sorry, I am very sorry. So this is V1, this is V2, this is V3, this is V4, this is V5, and this is V6. So V6 in the left mid axillary line, and V5 is at the left anterior axillary line, V4 level. So level of V4, V5, V6 will be the same, but this is at the mid clavicular line, this is the anterior axillary line, this is at the mid axillary line. Okay. Okay, and this is at the left sternal border, and in between that will be the V3, and this is V3R, and this is V4R. V4R is at the, you can see here, right mid axillary line, fifth intercostal space. So this is at mid axillary line, fifth intercostal space. Between V1 and V4R will be the V3. Okay. Okay. Now same thing here also. So V1, V2, V3. So this is third intercostal space. This is, sorry, this is third intercostal space, yes, and this is fifth intercostal space. This is fourth intercostal, I am confused. This is fourth intercostal space, and this is fifth intercostal space, and in between these two you can draw these two lines like this. Okay, and this is the mid clavicular line like this, and then anterior axillary line, and this is the mid axillary line. Between this V2 and V4 is the V3. Then V3R will be at the same level as V3, but it is at the right side, and V4R will be at the same level, but it is at the right side. Okay. Now see here, this is what these leads. So V1 and V2 are seeing the right atrium. V3 and V4 are seeing the septum. V5 and V6 are seeing the left ventricle. Similarly, V4R and V3R are seeing the right ventricle better than the V1 and V2. That's why V3R and V4R are used to know the right ventricular infarction. Okay, just remember this thing. Then comes this one. This is just to show how that, so when you see, if this is V1, this is V2, this is V3, this is V4, this is V5, this is V6. So what happens is, in the ECG it will be like this. As it progresses, the amplitude of R wave increases and S wave decreases from V1 to V6. V3 it will be biphasic, and then it will be like this, and like this, and then like this. So as the ECG progresses from the V1 to V6, the amplitude of R wave goes on increasing, whereas the amplitude of S wave, this is S wave, goes on decreasing. This figure shows why is the amplitude of V1 like this and why is the amplitude of V6 like this. Okay, if you know these two, you will know V2, V3, V4, V6, V5, V6. Okay, so first what happens is, first there will be septal depolarization towards the left side. See here, towards the left side there is septal depolarization. Because of that, V6 will be, sorry, V1 will be, V1 will have a positive wave, and because it is septum, it is not a large part of heart, so it will generate a small Q wave, small Q wave, small Q. It will generate a small Q wave. Now second step will be, the impulse will start spreading to the left ventricle. It will spread to the left ventricle, that is away from V1, and left ventricle is powerful, so the amplitude will be negative in V1 like this. So this is S wave. Okay, this is S wave. And next there will be, impulse will now travel to the right ventricle, and there will be right ventricular depolarization. So now you will have a small positive wave. Similarly, first depolarization is opposite to V6, that's why there will be negative Q wave. This is R S R dash wave. Okay, and this is Q R S wave. So this is one negative because of this opposite, and this is positive because it is towards V6, and this is again negative because the right ventricle is depolarizing and it is opposite to V6. So that's why. And now V2 will be along that, as a V3 and V3 or V4 will be somewhat biphasic like this. So this will happen from V1 to V6. Now this is the last thing of this video. We are learning the basics. Okay. So posterior ECG lead placement. Just see this. So where you place V7, V8 and V9, and when you will place, that is important. So when you suspect a posterior MI is suggestive by the following changes in V1. You should look at the V1, V2 and V3 leads. So there will be horizontal ST depression in V1 and V2, V3. Tall, broad R waves in V1, V2, V3. You will have tall, broad R waves. along with ST segment depression and horizontal ST depression. There will be tall broad R waves and there will be upright T waves and dominant R wave in V2, meaning R by S ratio will be more than 1. So something like this. Okay. So this is V1, this is V2, this is V3. So you can see ST segment depression in all V1, V2 and V3. And you can see tall and broad R waves in all the three. And also upright T waves in these three leads. But one thing, in the second lead, you can see the amplitude of R is more than S. So if these four conditions are met, you should suspect posterior MI. To confirm, there are two methods. Either what you will do, either in V1 and V2 you are having ST depression, you just uh, up down the strip, you just inverse the ECG strip, then you will see this as an elevation. This is one method. Other method is you place this V7 and V8 and V9 leads. So V7 should be placed at the left posterior axillary line, V8 should be placed at the tip of the left scapula, and V9 should be placed at the left paraspinal region as shown here. See. So V7 at the left posterior axillary line, V8 at the tip of the left mid scapula. What should be the level? The level should be same as V4, V5, C, nothing but fifth intercostal space. And V9 should be the left paraspinal regions. V1 and V3 should remain unchanged from standard 12 ECG. Please note that V6 is a good reference point for the horizontal placement of the posterior axillary spine. If you don't have access to a 15 or 18 lead ECG machine, then V1 to V3 in their normal position and use V4 to V6 will act as V4 will act as V7, V5 will act as V8, V6 will act as V9. You place at this position and then you take another ECG. Keep the V1 to V3 leads at their own place. So that's how you can take an ECG to confirm right posterior infarction by rearranging the leads in a 12 lead ECG if you don't have that 18 lead or 15 lead ECG. Okay. So what you will know, see this diagram. Again, these are seeing at the left ventricle. These are seeing at the septum. These are seeing at the left ventricle. These leads are seeing at the posterior inferior wall of the heart. Posterior inferior wall of the heart. V7, V8 and V9. So that's all the basics of ECG we have learned. So in the next class, we will learn systematic ECG interpretation, the clinical 14-point approach, step by step with maximum visual learning than theoretical learning. Thank you. We'll meet in the next video.